Okay, so we're just going to talk about neurological disorders in like the pathophysiology and sort of signs and symptoms, kind of very, very broad what's happening with a couple of these disorders. We're not going to go into in-depth, and when she comes in and she explains some of the medications, she reviews some of the pathophysiology and relates it to the medication, so she does an even better job of kind of reviewing this. So these are the objectives. We're talking about predominantly epilepsies. These are kind of reversed in the little bullets there, Alzheimer's, Parkinson's, and epilepsy, kind of reverse it. We kind of talk about them in different order in the textbook. And but they're all what we basically are covering. We review these again in special needs. You might have already talked about them a little bit in like Monica's class. So this can be kind of review, but these are basically what we're going to talk about. She also is going to talk a little bit about pain, a little bit of neuropathic pain as well, and then maybe some like headache, migraine, but it's not as heavy in this part. We're just reviewing the nervous system. These are neurological disorders, so they're going to have an effect on the central nervous system and the peripheral nervous system. You remember we talked a lot about this in the beginning, how the peripheral is divided into the somatic and the autonomic, which we talked about even further with the sympathetic, fight or flight, and the parasympathetic, rest and digest. So all of these, and then we go into the talk on neurotransmitters. So what's nice about neurotransmitters is that they kind of keep coming back. So in the beginning, it seems like kind of such an overwhelming topic, but they sort of keep reappearing because a lot of drugs work on the chemicals in our bodies, and those are some chemicals in our bodies. So that's how neurons talk to one another, is with neurotransmitters. So we have the central nervous system as our hub, brain and spinal cord, and then it sends out these little tentacles, these little neurons, and they house at the ends, they house the little kind of vesicles, or the places where they create the neurotransmitter chemicals. Then they release them. Remember, this is that synaptic cleft, is that little tiny space, like less than I don't even know, it's like half or a tenth of the width of a hair or some crazy thing. Super tiny little space where the neurotransmitters are released, and then they go over to receptors on the postganglionic cleft, or the postganglionic neuron. Starts another action potential, keeps that messaging going down the line, and then it heads down here till they're released at whatever target tissue that is. So eyes, heart, lungs, gallbladder, whatever it is, it does that process, and different chemicals for different parts of the body. So this is sort of just a review, pretty much, I think, of what I just. And then there's always some notes next to it. I'm recording it. Yes, I'm recording it. So neurotransmitters, we're familiar with a few of them. We've talked about acetylcholine. That's in like pretty much all of them in the preganglionic neuron. And then we talked about norepinephrine and epinephrine in just more the sympathetic. But there's another one too, glutamate, which I should have added there. But we'll talk about dopamine, serotonin, and GABA. And this week and next week with the psychiatric disorders, you'll start to get a full picture, because if you have an imbalance in one, but an excess in another, you get one kind of disease. And if you reverse that, if you have like whatever I just said, the opposite of that, you get a different kind of disease. So you'll start to see how the neurotransmitters start to affect different diseases. So we'll talk about dopamine, serotonin. A lot of people think of serotonin strictly as, just with the psychiatric mood, with depression or anxiety, the serotonin reuptake inhibitor drugs. So this is just a quick video, this little YouTube video that basically just depicts that same thing that I was talking about. The neurotransmitters going from the little vesicles in the neuron over to their receptors, starting another action potential. You can watch that on your own time. So the different neurotransmitters. So dopamine is very important in the process of movement. So we see patients that have Parkinson's disease have an issue with dopamine. So it has a lot to do with movement. Acetylcholine is involved in the peripheral nervous system, the skeletal muscle movement, and the regulation of smooth muscles. And we saw that earlier on when we were talking about cardiovascular disease and things like that. It can still affect other organs. It's not just the heart. So acetylcholine plays a role in a lot of these. It's also very important in the central nervous system in regards to learning and memory. So then we're going to see how that relates to patients who have Alzheimer's disease. So these are really important in a lot of different factors. So for balance, posture, and voluntary movement, acetylcholine is excitatory. So if somebody has an imbalance of dopamine and too much acetylcholine, if it sort of fills in that gap, then there's going to be a certain amount of disease symptoms are going to show up. And then dopamine is an inhibitory neurotransmitter, but they exist in a balance. So there's only supposed to be so much of one and only supposed to be so much of another. And so they imbalance because you can see they're sort of opposite, with one's being excitatory and one being an inhibitory neurotransmitter. So if dopamine is absent, acetylcholine sort of fills in, you might get too much of it. So some of these drugs are going to try and increase dopamine. Some of them are going to try and break down acetylcholine. So they're just trying to find that balance, that equilibrium. So GABA is another inhibitory. You can kind of think of it as like calming almost, gamma aminobutyric acid. And it's the presynaptic release of other neurotransmitters. So it's involved in lots of mechanisms. But GABA is sort of like calming, whereas glutamate always sticks out in my head because you guys, MSG, monosodium glutamate, are you familiar with that flavor enhancing food additive? Well, when I was young, my mom was like, it's a neurotoxin. It's an excitatory neurotoxin. I don't know why my mom knew that, but she would tell me that. So when I read this, it's so funny because I always think of it as food related and my mom, aspartame has it too. Aspartame's a neurotoxin, blah, blah, blah. So these are just things that I was told growing up, which may or may not be true. Do your own research. And, but so it's funny, it helps this stick in my mind because I have something else that I kind of connected to that was similar. So glutamate, so if that helps you at all, monosodium glutamate is a neurotoxin, but that's what happens when things get too excited. If things get too excited, they sort of wear out, right? They kind of pop their top and they wear out because they just are using a lot of energy. So glutamate is a major mediator of excitatory signals involved in the brain function, including cognitive memory and learning. So if you start getting too much of that and it becomes neurotoxic, then you're going to see an effect with cognition, with memory, and that's what we see in patients with Alzheimer's disease. Not to scare you about eating MSG. You guys think I'm like the scary lady that tells you scary things? Like I play scary YouTube videos about drugs. I'm like, you'll have all these strange memories of me. Okay. So with Alzheimer's, Parkinson's and epilepsy, these are all the neurological disorders that we're kind of reviewing. So with Alzheimer's, it's age-related predominantly, although there can be early onset Alzheimer's, which can be very sad. I had a patient when I worked over here at for Dr. Matsuda the first time I worked for him, and he was in his 40s and his kids were teenagers and he had early onset Alzheimer's. It was very sad, and I saw him for about 5 years, and I saw him, he was still coming in for cleanings, but I kind of saw the degradation of, you know, his cognitive abilities, and his wife had to be more and more present. And he was really young. I mean, he's probably, because I'm 43, so probably not much older than I am now when he got diagnosed. So that's kind of scary, but it's not common. It's more age related. Usually people over the age of 65 or usually up into 75 and 80s. It is chronic decline of intellectual abilities, starts with things like memory loss and abstract thinking, a loss of abstract thinking and judgment and learning. So the loss of the cholinergic neurons, which are important to memory, which is the acetylcholine. So that's cholinergic. Some of you are asking about the sympathomimetic, you know, that deals with the sympathetic nervous system, and this is more the parasympathetic and the cholinergic neurons. So acetylcholine is lost. Glutamate is increased, so that excitatory function is increased, and she'll, Dr. Merlot will go into a good detail about the plaques and the tangles that are what's actually forming in the brain and like choking off blood supply, and like there's like a literal shrinkage of the brain for individuals who have Alzheimer's, and there's kind of a buildup of what they call plaques and tangles, and she'll talk about that in a little bit better detail. And there's a video here too that you can watch. I think that's a video. Or is that is it an article? Is there a video link in the article? I thought there was a video somewhere in there, and it talks about it too, which is, so the article is a good review and then some video information as well. Causes are really unknown. There's some environmental factors that may or may not, you know, have something to do with it. They're doing lots of research on it, and other environmental toxins too. They look at lifelong diet habits and, you know, different things, stress and things like that. But in general, they're still researching reasons why it happens. Alzheimer's disease. So it's important for you to be familiar with these stages. So the early stage, middle stage, and advanced stage, there'll be questions on the exam related to the staging. So make sure you know the early stages is just some loss of memory, maybe, you know, trying to find words harder. I feel like I have it right now because I'm always like grappling for word choice. And so, but people have that feeling like they just can't say what they want to say as easily. They maybe get a little bit confused as to what they were, you know, stress can make all of that happen too, FYI. So if you're stressed out, that can also just be it. But change in personality and behavior. So it's usually something that family members start to notice. Middle stage includes inability to work. So at this part, you're really pretty, you're at a point where you're not working, you know, the diagnosis is full on, and you know, you're probably in some level of a little bit more care. And then advanced stage, they're in far more advanced part of the disease. There's full caregiving. They may or may not be bedridden, but at least certainly they're not doing anything that you'd consider to be like healthy, functioning, normal activity. And then it just degrades from there. They say most people who have Alzheimer's diagnosis, it's usually no more than like 10 years usually but they have, you know, progression can differ for different people, and they do have medications to try and slow the progression. So drug therapy can be difficult to manage. Dr. Merlot will talk more about that. So just to get you thinking, so the main problem is the destruction of the cholinergic neurons. So less acetylcholine is being produced. And there's more of other neurotransmitters that we don't necessarily want in excess. So if you were a drug, what would you instinctually try to do? Yeah, keep acetylcholine, prevent it from being broken down as fast so it's more available. So that's good. So that would be what you'd be trying to achieve. Okay, Parkinson's disease, the next one, it's another age-related, although just like Alzheimer's, there can incidences of early onset, and there can be Parkinson's-like diseases as well, as there's like true Parkinson's, but then there could be Parkinson's-like diseases or symptoms that can even come from medications. Medications can actually give Parkinson's-like, and you'll see that that's because of what transmitters. But it's chronic, it is progressive, it's a degenerative disorder of the central nervous system. And you can see in a healthy patient, they have this good supply of dopamine. They're releasing a good supply coming into the receptor cells, but then you have this good sort of recycling of it. But in a patient with Parkinson's disease, they're just not producing it as much, so their receptor isn't picking up as much, and then this kind of recycling process that your body kind of does to get neurotransmitters back up into the neuron, it's just not working as well for somebody with Parkinson's disease. So we won't go into this too deeply. You don't need to understand this on a very, very deep level, but there's different systems in the body that have to do with initiating movement and then controlling movement. And those are called the, I always think I know how to say this word, and then when I want to say primordial, and that's the word that's in my head, but pyramidal system and the extrapyramidal system. So those systems are the main systems that help you initiate a movement, like I'm going to go move my arm over here. But then the other one, controlling, is like, I'm going to brush my teeth, or I'm going to put on mascara, or I'm going to do something with like a controlled movement. And so those systems are affected. The controlled system is affected when somebody has Parkinson's disease because of the decrease in dopamine. So that's, so just knowing those words, those phrases, recognizing those systems is important for like a quiz or an exam. We don't go into a huge amount of detail with that, but just knowing that that's what's affected. And it's specifically due to the decrease in dopamine. So a quiz, if it asked you like, is it the decrease in acetylcholine or GABA, dopamine or serotonin, you'd want to recognize that that is specifically due. So the area of the body or the area of the brain where this is really happening, like a lot of the dopamine's being produced, and you start to see it shriveling away and kind of shrinking away on patients that have Parkinson's, is this area of the body called the substantia. And you can see how this just looks a little bit, this is a healthy, normal body part, substantia nigra. And then you can just see the one down here just looks a little bit more shriveled, like it's a little wrinkly, it's lighter colored. And, I'm assuming this is the color it should be. And you can see how this sort of membrane is kind of coming off. It's just shriveled and doesn't look as healthy. So it's just not producing the same amount of dopamine cells that, produce the dopamine, the neurotransmitter. So it's sort of a hallmark of somebody with okay, so again, unknown causes. There are some environmental things, or some, people could have symptoms that are similar to Parkinson's through head trauma, head brain tumor, stroke, things like that. This is important to know for this class and for special needs as well. You'll see in the notes that acronym TRAP. That's something to be familiar with when it comes to Parkinson's, because patients that have Parkinson's tend to have tremors. They can have kind of a little rolling, shaking in their hand. You could see it in their tongue. And then they have this rigidity, this sort of rigid movement to their walk. And then the akinesia or bradykinesia is kind of slow, difficult movement, slower movement, and then postural instability. So they might fall easily, they might need more help getting up and walking. So these are some hallmarks. The other thing too is this masked expression. There's not as much facial expression. And then this sort of short shuffling step. So all these things, because if you have a patient with Parkinson's, you're going to help them come from the lobby into your room, sit down in the chair, all these things, and then just being aware of the shakiness, their difficulty with oral hygiene, all that stuff will come into play. About it more next semester too, thinking about this. Just a video for you to watch. Michael J. Fox has Parkinson's. He's had it for decades. Very slow progression with him. Yeah.
This is kind of random.
Yeah.
And then she left the room like to let her get dressed, and the lady fell over because she couldn't like do it herself, and like they had to tell like everything.
Was she older?
Yeah.
She was an older woman. Yeah. They definitely, and they might be embarrassed about how little they're able to do. And they might kind of be like, oh yeah, I can do it, but you can't. My grandma had Parkinson's disease. Yeah. She was embarrassed. Oh, that's sad. Yeah. It's definitely, and it's progressive, and people don't always want to admit when they've gotten to a point where like, I can't do what I, was able to do a month ago or 2 months ago or whatever. So again, drug therapy, I'm going to kind of skip this one just because I see our guest speaker out there and I want to make sure he's going to talk a lot about this. So obviously, again, it's the drugs target trying to help that imbalance. That's what the drugs are going to do. So they're going to try and get more dopamine into the brain. She'll go over some of that. So epilepsy, you guys talked about this a lot, I guess, with Monica. She's with medical emergencies. So just a little bit of background information there. That when somebody has epilepsy, they can have partial. Usually there's no loss of consciousness. It might be sort of like a little blank stare. You might not even know something has occurred. So of course, the one that's more prevalent that we think about are the generalized seizures that can be sort of, they used to say petite mal and grand mal, so small in nature, maybe not so much of like that seizing, that constriction that they hold, and then that rhythmic beating of the clonic phase. So some of you were asking about that for the tonic-clonic. So the tonic is just that total contraction, the whole body just is like, and they might even have like an epileptic cry as the air is like forced out of their lungs. And then they go into that what you really think of as the seizure, that like rhythmic beating, and that's like the muscles relaxing and contracting. Epileptic status epilepticus is the medical emergency. They are going to the hospital because that lasts far too long, and they need treatment at the hospital. 50% of cases are idiopathic. They don't really know why, but it can happen from trauma, infection, fever. Different medical conditions can increase somebody's risk factor for about a third of the patients will have that aura, that kind of like feeling that something's going to come, something's happening. And I mean, I guess that would be a nice seizures because you're like, I'm about to have a seizure, opposed to just having it happen. And then these are, again, just talking a bit more. And I think you guys actually, I didn't realize this, but last year they said that Monica has the same video in her thing. They told me that last year. I was like, well, that's because it's a good video. I found it on YouTube and she found the same one. So some of this is repeat. Trauma obviously is something that is going to be one of the biggest concerns, and then oral trauma too. Also trauma to the head and neck, biting the tongue, aspiration if something was in their mouth, if they were in the middle of eating or sucking on a candy. Concern. Drug therapy, the problem depends, and it's different types of seizures, different types of medications. And so we'll show, Dr. We'll talk. That was fast. I can do that. So 5 minutes, you guys, if you just want to get up, run to the bathroom, I'm going to let her get up, and then